So a very little bit about endo-AVF maturation assessment is different to open AVF. In the open AVF assessment, the assessment is primarily clinical, the rule of sixes and so on, but it doesn't really apply so well to endo-AVF. I think the endo-AVF assessment is primarily ultrasound followed by clinical, partly because doesn't need to be so prominently palpable compared to open AVF. The dialysis nurses, in my opinion, they're miracle workers. They can cannulate things that you can't feel. So you don't need the 6 mm diameter, you don't need the 600 mils per minute and so on and so forth. You don't need you do need a straight segment, but I'm going to show you some of the cases where they managed to cannulate even though it's much less than 6 cm. The formal ultrasound scans are done much earlier, as we mentioned earlier, 1 week, and then at 1 month, so that you can do earlier intervention. And the flow rate that seems to support so far is more than 300 to 400. So you don't need 600 mils. If scan looks like when we assess it at 1 week and 1 month. So the thing to look for is the brachial artery flow. If it's less than 300, then probably there's a prompt for intervention, even if it's 1 week. That's what the proctor told me. And then, of course, you want to know your anesmosis and your perforator sizes. I'm going to talk about the straightforward cases. So there's always that one guy that has the technical failure. It's going to be me because can we switch? Because I built my deck for Windows and actually it's Mac. So can we switch over to the second computer? I'm not seeing it. Yeah, okay. So, sorry, I realized I forgot a prisoner case. Can you switch back to the previous slide? In my excitement to show I forgot to talk about the patient. So this is a 65-year-old lady who had a CLL and ESRS for minimal change disease secondary. And then she underwent a right radial endo-AVF with ellipsis. This was the 1 week scan. So at 1 week, you can see the brachial artery flow is 382. Sorry, the numbers are kind of small. Perforator 2.8, diameter of the anastomosis 2.5 is still okay. The outflows in the cephalic and basilic are not the best. The basilic is only 285, the cephalic is 173, but we thought we would watch for a while. And 1 month later, the scan on the right, you can see the brachial artery flow is still not the best. It's 295. There's been not much increase in size of the cephalic and the basilic. The flow rates are not terribly encouraging, 82 and 270. So we decided to put her up for angioplasty. Sorry, now can we switch the computer? Sorry about that. So this is a straightforward case. In that by now we had kind of figured out how to do it properly. So come from the artery, and the runs showing 1 second. Oh, sorry, no, this is not the right patient. Sorry. Could you go back to the slide and see which patient it was? Go back 3. Oh, I have the connector. I have the thing. So this is AD. Oh, sorry, I opened the wrong slides. That's strange. Okay, I somehow don't have the angio for this picture for some strange reason. Either that or I don't know how to use a Mac properly.
I think you had it before then,
right? I did at the start, but I don't. Here it is. It's here. Strangely, it's not on the tabs on top. Okay, so let's select all. And yeah, okay. And now it's in reverse order. This is exactly what I didn't want to happen. Sorry, because this is a Mac, everything is backwards. So you have to bear with me. The pictures are flowing.
Okay, I'll switch it to this one.
Okay, the angiogram is reversed, but essentially what we had to do is we did a Sterling balloon across the anastomosis and perforator. It looked like that after that. And then treated the outflow. And I think ultimately we needed to do a cutting balloon. Yes, so we had to use a cutting balloon because it didn't quite efface fully. So in the end, I used a cutting 5 and then I tried to post dilate with a 6 and it looks better after that. So back to the slides, sorry. It's going to be back and forth today. So 1 week after the angioplasty, you can see on the right, the brachial artery flow has gone up from 295 to 1.2 liters. And the outflow vein flows were much more respectable. Anastomosis has, of course, because we've dilated it, it's gone from 2 to 4 millimeters. I'm going to skip this patient in the interest of time. It's another straightforward case. Essentially, same thing. I don't have the 1 week post because we just did it, but on table the flow rates were much better. So these are the lessons that I learned, which led us to be able to do the cases as straightforward cases. Firstly, I used to do them all under GA because I thought it's, you need the dilation, GA, RA, you don't want vasospasm, but in the end we found out you can actually do it under LA without any issues, provided you use a cocktail. So I'll talk about the cocktail shortly. For the radial endo AVFs, we'll start with the radial artery micropuncture. I usually go with a 6 French sheath now because I found that almost a lot of them we need to use a cutting balloon. You can shove the cutting balloon through the 5 French sheath is against instruction, but what happens is it tends to slice the end of the sheath apart. So when you're taking out the sheath, then you get bleeding all over the place. So now I just go with the 6 French. It's better to do a angiogram of the artery to check in roadmap before you shove things out. The sheath in cocktail, we use GTN, verapamil, and heparin. So it's all mixed up together in one syringe for ease of use. I tend to use a Command 18 and an angle trailblazer rather than a burr. One of my first cases, I think that a lot of our patients have calcification. So the burr was actually catching on the calcium, and it occurred to me that it's quite hard to track in some patients and you can end up with dissections. I like the Command 18 because the wire is very gentle. The angle trailblazer, surprisingly, the angle is quite good. So it's almost as good as a burr. And then, angioplasty, usually a Sterling 4 or 5, rarely 6, but often have to use a cutting. I call it an inevitable lesion because I think 90% of the time they have always been resistant to the Sterling. And then they do the final runs and do the sheath out cocktail, which is basically GTN and verapamil. The idea of all this is to prevent arteriospasm. You don't want your artery to clot up. Nowadays we use a TR band, so it's convenient. A TR band is this device that you inflate over the radial artery so that you don't have to do prolonged compression, and it's supposed to maintain distal perfusion so it goes through. One of the juniors will come take out the TR band in 2 hours and send the patient on their way. So can you balloon the whole venous outflow? So this is one of the cases that we did that. It's a patient, he's 59 years old. He's got diabetes and ESRF secondary to diabetes. He had a left radial endo AVF. This was 1 week after his ellipsis. So the numbers, you can see that his brachial artery flow rate is not bad, 404, perforated vein is 2.5, and anastomosis 2.5. So it looked decent. We opted to observe it. Hopefully the flows will increase in the cephalic and the basilic. At 1 month, which is the picture on the right, the flows in the basilic did increase to 450 to 535. The brachial artery flow is better, 500 from 400-ish. But you can see the perforated vein is now starting to become smaller, and the anastomosis also becoming smaller. I'm not sure if this is anecdotal, but it seems to be more, for us, it seems to happen more with the ellipsis than the wavelength. I'm the director of the vascular lab, so I've been seeing all the scans that we've done so far, and that seems to be what I've noticed. So on the basis of this, we decided to watch. So at this time, this is one of our earliest cases. We were very unkeen to jump in and intervene too early. And so what happened on the right side is, so this is 3 months later from that previous scan. They were having problems cannulating the cephalic vein because it was small. You can see the diameters on over here, 3.2, 2.2. They're all rather difficult. In fact, In fact, I'm amazed that they could cannulate at all. And the perforated vein and anastomosis remain smallish at around 2 mm, sub 2 mm. So this is when we decided to do a maturation procedure. This is one of the earliest ones, so I thought, why not come from the top down? And this is why I learned that you shouldn't come from the top down. Yeah. Let me see, where is it? I seem to be... one second, I have a very short-term memory. DT. Yeah. Yeah. Thanks, man. Control A? No, it's not Control A, it's Command A, because it's different. And then it's Option Spacebar. Okay, so yeah, this is the correct sequence. So this is us coming down the cephalic from the top. And when you shoot of course, because you're coming from the top, you have no map, you're against flow. So I spent a lot of time trying to figure out what was going on. I tried to reflux and nothing worked. So I couldn't find the anastomosis at the end of the day. And that's when I learned not to do this again. Yeah, I did try ultrasound, but at the time I was still a little bit newer, so it was confusing, and I decided to just do what I could. So let's see. So I'm just going to zoom through these. This is just me trying to find anastomosis, and ultimately I couldn't quite find anastomosis, but I decided to try and mature up that very small cephalic vein, which is near the sheath. So I hit that with a 6 Sterling, and then did the rest of the runs. I think I came back and I tried to mature it a bit more with a longer balloon. That was me accidentally pulling the sheath out, but it was all right. So I tried to mature the whole cephalic outflow up with a 6. So it looks prettier now. It looks bigger, but again, learning lessons. I think I hit it a lot of times because it tended to spasm, that's right. And that's one of the learning lessons. The flow rate is much lower here and it doesn't stay open as well as a normal AVF. It doesn't behave anything like a normal AVF when you do a BAM. So at the end of the day, I think I got decent-ish pictures, but I decided to stop. I used a cutting balloon across the anastomosis because it was wasting there. You can see the 5/8 Sterling just would not efface. Okay, so I think that's pretty much all I did. So can we move back to the slides? So what happened was it didn't work. It actually thrombosed off a week later on the bedside scan. The part that had balloon larger near the origin of near the bifurcation into the cephalic, the ostium, had thrombosed. So I did a thrombolysis and angioplasty, but this time I learned my lesson, so I came out the artery. Can we switch back to the second computer again? Okay, so this time much easier because we're coming from in the direction of flow. You can see exactly what's going on. And you can see that that's the stump there. This is a laser pointer. So that's the cephalic that I had plastied, and that's the narrow part that was thrombosed. So slowly found my way into it. Sorry, this is the entire angio, is the raw pictures, because I thought it would be easier to control. So I managed to find my way across the cephalic. I think I used the urokinase to lyse and then plastied it after that. Got a flow channel going, got it looking fairly decent this time. Perforator and anastomosis were all right at this point because I already treated them previously. And that's it. Just use the 5 mm balloon across. So I basically tried to mature the entire outflow again, and it looked pretty decent in the final pictures. I think I used a 6 after that, and it looked really nice. But that's also something different. So this is what I learned. In the long run, I think we followed her up for a year now, followed him up for a year now. Can we go back to the other picture? So 1 week after the intervention, of course, the numbers are better. The anastomosis has gone from 2 to 3. The perforator is bigger. The flow rate has gone from 400 to 658. It looks nice on the drawing that they drew. The cephalic is bigger because we matured it. But 1 year later, what you're seeing here is the cephalic is actually shrunk down again. So all that maturation didn't really work. The cephalic flow is poor. But interestingly, what she has now is she has an aneurysmal dilation at the start where we hit it with the 6 before. And the nurses were actually able to cannulate that pretty easily. So somehow it worked against expectations. And she's able to dialyze. They're using that blob as the V cannulation site. So next question is, can you come from the top again? I think, yeah, this is another learning lesson that I learned. So this one is TSK. This is a 55-year-old lady, ESRF from IJ nephropathy. We did a left radial endo AVF. This was at 1 month. So, oh, sorry, I think I had a 1 week. Oh, sorry, I forgot to write it down. Anyway, the 1 month scan, the flow rate wasn't too bad. Brachial artery flow was 516. Cephalic and basilic 227186 are not too bad. Diameters are all right. But what happened was that this patient was seen by another colleague of mine, and she did a bedside ultrasound in the clinic, and she found that there was a focal stenosis of the cephalic vein just above the elbow for 3 cm. So she put it up without telling me for a balloon-assisted maturation, and unfortunately there was no scan done because she had just done a focal scan herself. So I got a surprise when I went over, saw my list, again, this was one of the early ones, so I tried to come from the top again. This is the balloon-assisted maturation. Oh, it's not. Okay, they didn't put it in. Never mind. So basically, I tried to come from the top, but what happened was the whole thing clotted off. So the cephalic was now gone and it's kind of dismal looking. You think it's time to give up, but I came back and did a thrombolysis from the artery. So I got the thrombolysis pictures. Can we switch? Oh, you done it. Thanks. So coming up the radial artery, that's the showing that everything's going down the basilic. That's the stump of the cephalic there. So eventually managed to cross into it, thrombolyzed it. This is lacing with urokinase. I thought it'd be able to go faster. And then ballooning. And getting it eventually after many, many balloons. I think there was a larger Sterling and a cutting balloon as well. That's the cutting balloon going up there, where the resistance stenosis was, and ultimately got a pretty decent picture there. So yeah, so this is fast flow down the cephalic now. And that's the end. Back to the previous, please. So 1 day after the scan, the cephalic has been resurrected, 260 mils per minute, 4 millimeters, not too bad. The brachial artery flow has gone up from 260 to 700. And then 6 months later, it showed that this one actually did stay open. So the cephalic was a decent size. They were cannulating well. And the brachial artery flow rate was now 1 liter. So this is my last case. Sorry I've taken us so much time. This one is notable because the only reason this patient can use her endo AVF is because the dialysis nurses are fantastic for her. So 56-year-old lady, she's got type 2 diabetes, ESRF, hypertension, the royal flush. But she also has stage 4B endometrial CA with resection and chemotherapy. So this was our map. She underwent a left ulnar endo AVF wave link. And the pre-map didn't do it justice. It looks okay, just a little bit twisty, right? Later we're going to see it was very misleading actually. We all got foxed. So post-op day 1, the brachial artery flow was 260 mils. The perforator was 3.9 millimeters. At 1 month, so previously it was 3.9 millimeter perforator. Now it's 4 millimeters. It's about the same. The brachial arterial flow went from 260 to 350. the sizes of the cephalic vein was still rather small, 2.7 to 3.7 mm. So it looks promising, but not big enough for cannulation, right? Basilic vein was about 3 mm. At 2 months, we now noticed the cephalic vein had a poor thrill, and most of the thrill was going up the medial upper arm, the brachial veins. Anastomosis at bedside scan was only 1.2 mm now. And the volume flows were not great in the cephalic vein. So we decided to put her up for angioplasty. So coming up the artery this time. So we found our way into the cephalic, but look at that. That is not really a cephalic. That's the problem. Instead of a cephalic vein, she's got these little tiny twigs coming off. And so didn't really know what to do. So we just, I just ballooned up the usual balloon. There's a waist there. Tried to get it a bit better, but everything's going out the basilic. It's gotten, oh yeah, we called the brachial vein at this point as well, because a lot of the outflow was going up the brachial vein on the scans just now. So just skip through this. Okay. Yeah, I regret doing this now. Okay, anyway, I think, no, it's faster this way. So this is after coiling the brachial vein, the medial brachial vein. And that's the outflow. It's not looking very good because the cephalic is really not the best. We put another coil. So I'm going to skip that to save everyone. 4 months later, the flow was improved with basilic and cephalic veins. So we've got volume flow of 172 in the cephalic and 373 in the basilic. So the coiling of the brachial vein helped. The cephalic vein origin was largish, but as we pointed out just now, it splits up into this network of tiny little veins. But somehow the nurses were able to cannulate the median basilic as the A side and the cephalic stump, which is that 3.3 mm part, as the V side. So against all expectations, they were able to cannulate. One of the nurses was able to cannulate, and then that nurse actually went to teach all the other nurses in the dialysis center slowly how to do it. And this is 1 year later, so unexpectedly that cephalic stump has just gotten bigger and bigger. So they are now able to, all of them are able to cannulate this part fairly well with ease. I think it's about 5 millimeters, and she's dialyzing on it. The rest, I didn't, sorry, yeah, we'll skip over that. So my learning lessons was that endo-AVF angiographic salvage is quite different from conventional BAM. The flow rates are lower, so if you do long segmental balloonings of the outflows, it doesn't seem to stay open very well, and it clots more easily. I think you must do the anastomosis and the perforator concurrently, or it's not going to work because the flow rates are much lower. I can't figure out how to come from the vein across the anastomosis, and as mentioned earlier, try not to unless you're forced to. Coming out an artery and doing the same thing every time is how you can get the straightforward outcome. You just repeat as a template. And that's my end of my talk.
We just move the places. Sorry. It wasn't my decision. Sorry.
Don't blame the messenger.
So the story is, I think it's a radial waveling. You just nod or say no, Jackie. Radial created in January, one intervention. No, it's I have to. Okay.
Yes. Yeah. So, yes. Yes. Yeah.
I don't measure.
So require compression or no need? By now, I think no.
Okay, so you see the ultrasound, and I don't know this fistula, so I don't know what outflows, what's so first things when I would see a endo AVF, I would look into the brachial artery and brachial veins. So if you see big brachial veins, it means that there's still a lot of flow. Also, you can add the color to see whether there is a color flow there. Yeah. Where's the color flowing through the brachial veins? And as you can see, there is basically no color in the brachial veins, which is a good sign. It means if the flow is total flow is good, it goes into the superficial venous system. Sometimes a little bit, it can go into the forearm veins, but usually the valves stop it. So the first thing what I would do in this patient, I would just, after I failed the thrill and did augmentation, etc., I would measure the flow. And accidentally, I realized that there is a coil in the brachial vein, which was placed either during the creation or during the secondary intervention. So can we turn the, yeah, perfect. Again, one more time. Yeah, I don't need the color. So let me try to adjust it. No, another direction again. Yeah, perfect. Can you activate the PD now? Okay, now let's increase the scale. Again, well, he has a really nice flow. You can see there is basically no resistance, and I'm on the, I hope I'm still on the artery because it's not simultaneously. Yeah, can you freeze it? Okay, good systolic and high-end diastolic flow, no resistance. Let's measure the size of the artery to see how the flow is. I would say it's probably 1,400. Just trying to show off that I know a lot of things. No, it's not 17,000, don't worry. Well, okay, 18,800. So since we didn't see any flow in the deep veins, it is expected that everything goes into the superficial vein or veins. I don't know whether he has singular or dual. Now I know it's dual. So let's find the anastomosis. So we follow the brachial artery. Yeah, maybe the arrow because, or the pointer to show it, just so they know. Because usually you look into thousands of different vessels. This is the brachial artery. So we go now down, and there's the bifurcation. That would be the radial artery, which is big because it had to feed the fistula. And that would be the anastomosis, in my opinion. Because when we go further down, the artery becomes really small. And then we go a little bit high. We see how big it is. So this is the anastomosis. I would measure the anastomosis in the transverse mode, but you see it's big enough. And then what I would do, I would visualize the anastomosis in the longitudinal projection. That's the anastomosis in the longitudinal projection. Here's the inflow artery, outflow artery, the anastomosis, and the juxta-anastomotic radial vein. And you see it's slightly pristinotically dilated here. Then there is probably non-significant narrowing because his flow is 1.8 liters. And then it goes towards the brachial vein, which was probably coiled.
Just one interruption. This is previously having a stenosis. So we angioplasty 3 months ago. So I think it probably have a little bit of narrow down back, but the flow is very good.
Yeah, so I would measure here the diameter to see, but I wouldn't treat it because it's completely asymptomatic unless he has problems with dialysis. And the flow is so good that I wouldn't treat this even if it is 3.2 millimeters or 2.8 millimeters. Let's go back to the transverse to make it a little bit easier. So again, anastomosis, radial vein, the slight narrowing in the radial vein, perforated vein, thank you. The perforated vein, the big perforated vein, some ulnar perforated bridge here, which we learned during the mapping. And then this goes up into the cephalic. And then I think I saw the bridge to the basilic there. So what I would do, I would measure the diameter and then activate the color just to see what the flow is. So just to see how the distribution of the flow is. So we know, you want to measure? Yeah. Just to see what to expect, because it is important in my experience to do the follow-ups routinely also if the fistula works, because it can shift from the cephalic towards the basilic. This is 6.3 millimeters, and now we will just do the flow measurement in the basilic vein. Just, yeah. Just to see from, it's okay, it's just approximate thing. You don't have to, oh. So you can see it's really flat. You can just freeze it. Yeah, and just measure it. So from the strength of the color, it looked like the basilic didn't have decent flow in it, which is good because we want the cephalic more than the basilic. But it is good to have a basilic as an option for the future, you know. So this would be what, 640. The machine says 640, and it's in the vein. It's approximate. So 1/3 is in the basilic, and then we go back towards the cephalic. This is the cephalic. So we see decent caliber. We see it's really superficial up until the proximal upper arm. Can you activate the color, Vicky? We see what I like in the color is this one. This we have on our machine. It's TDI, PVI or something like this. This just doesn't mix the colors, but you can see the strength in this one, and you can see the strength in this one a little bit lower. So do you have a B-flow on this machine? I think it's coming. No, it doesn't. Okay. So the B-flow is kind of like a color using an angiogram in an ultrasound. It really shows the strength of the flow. So we would measure the diameter, which is really good, and the flow in the cephalic in one image. So can you put a PV on it, Jackie? Or PW? Sorry, German accent. And again, the vein is approximate. You would compress the vein, so we usually don't measure the flow in the vein. It's just to see how the distribution is. And in my experience, the only reason why his cephalic works so good, although he has dual outflow with good basilic and good cephalic, is because his total flow is high. Usually, if it's basilic dominant and the flow is okayish, you see there is 800 in the cephalic, 600 was in the basilic, so we have already 1,400. There are probably 100 to 200 in his arterial system and some couple of hundreds in the deep venous system, somewhere lost. We cannot measure as a difference to surgical one. So all of the patients I had with dual outflow, with good basilic and good median cubital had a high, because he's kind of a high flow, right? 1,800 would be considered in some, especially in Asian countries, as a high flow. So yeah.
Well, Mr. Tan actually went during the creation. I actually put a restriction tie for the basilic as well. But as you grow that, I think the tie also dissolve. That's why you can't see very much of any narrowing over the basilic.
Was it a micro?
Yes, it's a micro. Yeah.
Thank you.
Thank you very much, Mr. Tan. So maybe just ask Mr. Tan, how is the needling process from like after the creation until now?
Okay, so I had the the cannulation started in I think in April, right? Yeah, March to April, and at the beginning was okay. Then after that, it has some issues, but after the angioplasty, it was very good. I don't have any like pressure problems like before the angioplasty. They had a lot of every time like I do the dialysis sessions, they have the pressure either low or down on the V point. Yeah, on the V point. Yeah.
At the beginning, you also acutely
too high. Yes, I've been on 250 since after the angioplasty. Yeah, it was about like sometimes about 200. Basically, it won't go beyond 200 before that.
And now it's 250.
Yes.
Why won't they do 400?
No, I'm doing HD. Yeah.
This locality.
Yeah, we don't go over 400.
But I mean, he can probably have half of the day off dialysis if they do up to 350 and 400. Is it the needle size, the gauge size, or? How long do you dialyze per day? 8 hours? 4 hours? And it's enough? 3 times a week?
Yeah, because our guys our agents are quite small in size. So
No, I know that in general there is a lower flow, which is good. We don't have 450, 500, which is in the United States too. We do 250 to 350. But in my surgical brain, it would mean if it's 150, 200 flow, dialysis flow, then the patients need to dialyze probably a couple of hours longer, right?
So
If the fistula is as good as his one, is there any reason not to go higher and reduce the time for dialysis? Surgical way of thinking.
So because phosphate is a time-dependent excretion, so we actually need that 4 hours because it's a 3-compartment distribution.
Okay.
So even if you do get a good clearance URR, that doesn't actually clears out the phosphate. So we still need that 4 hours or the minimum 3 hour 45 minutes kind to achieve a good phosphate control.
The water extraction, like a time, it takes 4 hours and I so much water to extract.
Yeah.
So it's more hospital than taking a short time.
Yeah. Yeah. Very good.
Very good.
It was not a question. It was a statement.
Great, thank you. Thank you. Thanks, Robert. So we are running behind time, and so in the interest of time, we will continue with the program. Next up, we have Dr. Pang. Dr. Pang is our consultant nephrology in the Department of Renal Medicine. She will share with us some of the tips on how to cannulate this fistula. So a lot of time, we can have a successful fistula that is created, and then ultrasound, it shows a good flow, but the nurses can't cannulate it. So a good fistula that is looked ultrasound sonographically is not being usable. So how do we actually overcome that problem? Because our nurses are actually very used to large fistula. So when we change this, it's actually a big issue for us. So Sujian will share with us what are the tips and tricks on overcoming this problem.
Thank you. Thank you, everyone. So I have no disclosure. This is my disclosure. Okay. So as you have known that the patient who has got endo-AVF created, they will be reviewed by our vascular surgeon in the clinic. So when they come to us, they feel that this is a fistula that is ready to cannulate. So in my center, what we do is that the nephrologists, my team. So what we'll be helping is to choose the cannulation zone and working with the dialysis center, which are basically in the community dialysis center, to help them in this process. Okay, so what we do is that, as you have seen, that we will always have a post-creation scan. And the post-creation scan will actually tell us what are the flow, what are the diameter in the superficial and the deep vein. So this is what we always looked at first. And why is it so is that to choose the cannulation zone, we need to know where the flows goes. And what are the predominant flow goes? As we know that as the anastomosis are created either at or near the perforator, the flows actually goes multi-directional. So you could actually get the superficial veins that get mature, but sometimes also goes into the deep veins. And what we looked at is that as we already talked about, we know that this brachial artery flow is basically a sum of basilic vein, flows from the basilic vein and the cephalic vein, as well as the deep vein, or some even in the forearm vein. So for us, we look at the scan and see which is the predominant flow veins. So in this case scenario, if we have 1,000 flow in the brachial artery, and 500 of it actually goes to the cephalic vein, clearly this is actually a cephalic predominant one, which is something that we would like, just like the earlier patients where we could clearly see the cephalic vein, which is really more lateral to the bodies, which is something that our dialysis nurse actually likes. What they are familiar with in terms of cannulating. The basilic one will look like something which is very similar to what we see, even though it's a split flow. But again, that choosing between the basilic and the cephalic vein can be more visible. Hence, that's what we'll usually do is that we'll mark up for them. So in this case, the upper and the lower cephalic vein of the upper arm actually are cannulated, and also take notes of the cubital vein are also cannulated in these particular patients. And in basilic vein predominant one, you probably looks something like that. Usually these are actually some of our patients which are being cannulated. You could see that the superficial vein are actually not very obvious. Having to cannulate is actually not easy, and hence that refers to the pictures on the right. These are actually the potential sites for cannulations for those that has a basilic vein. If you actually take a note where the elbow crease is, and usually for dialysis nurse, the needle are usually about 2 cm below the elbow crease due to obvious reasons, because there might be movement. The injuries to the back vessels who tells them to place tourniquet, because the endo AVF tends to be softer, and that the tourniquet can actually help them in terms of getting successful cannulation. We also pay attention to segment that is superficial, which is commonly at the area of the cubital vein is usually very superficial, or even the lower basilic or cephalic vein also can be quite superficial as well. So as we know, most dialysis nurses actually cannulate at about using a 25 to 30 degree entry angle. And often for fistula that is like normal, not too superficial or not too deep, it will be all right. And this is what they are familiar with as well. So however, for segment that is very superficial, which is in some cases, what happened is that we do actually has a lot of back wall injury and cannulations injury in the beginning part, because first, they couldn't actually see it. Second, it is more superficial than they would expect. So what we do is that we will actually pay, basically when we do marking, we will basically specify what's the depth, so that we will tell the nurses to actually go more shallow than usual. The other option is actually using a shorter needle. In Singapore, basically most centers use the 1-inch metal needle. The shorter needle is not something that it's available. So changing angle is the key. Entry angle. The other thing is about the use of plastic cannula. As we know that the cannulation sometimes, because it's just a few cm below the elbow crease, and using metal needle, there's always this concern. And what the dialysis nurse actually does is that they actually tell the patients not to move the arm, keep the arms actually, extended for over a 4 hours session can be quite tricky. So, plastic cannula definitely is something that will make it more possible in that way. And it actually, currently the shorter plastic cannula are made available for us as well from B-Bond. And this is what we do. So the patients come to us. This is the marking that we do. As you can see that we mark the cannulation zone, and we also indicate the depth and directions of the needle as a guide. And all of this actually routinely done, photo taken, and then we will send to the dialysis center. So these are some of the experience that we have in terms of the cannulation zone. We sort of have a split, more of a basilic vein, unfortunately. And of the 19 cases that we started cannulating, you could see that the medium cubital vein are often used for either one of the needle cannulations. And this is our protocol, as just sharing as to that we have always wanted to know if this a fistula that can be cannulated. So you could see there is a series of workflow that involve our coordinator, our surgeons, the VSU, and getting an arrangement in terms of angioplasty. In some scenario where they had problem with cannulation, we actually bring them in inpatients and do it by one of us of the team, either usually under ultrasound guidance and using plastic cannula. And so, I mean, for what I learned is that this cubital vein is often not suitable in surgical cannulation, surgical AVF, but it's often the case in endo AVF. We actually go around and also do a roadshow teaching the community nurses about, changing the angle. And of course, if we want to ensure early successful cannulations, it's definitely a multi-D effort, as we have shared. And we, for us, we will always be ready to help them cannulate using various methods, being a bridge whether to balloon-assisted angioplasty or some sort of salvaging in order to make life easier for the community nurses. So with that, that's my last slide. Thanks.
Learning quite a bit. So I'm just going to share some of the challenges that I faced when I first embarked on this. So just recap of the endo AVF. So essentially, we rely heavily on the perforator for this to work, right? To divert the fistula which is created in the deep system to come up to the superficial system. So, so for the wavelength, we have just heard that we can create the anastomosis between the ulnar artery and ulnar vein, or the radial artery with the radial vein, as long as it's below the level of the perforator. Whereas for the ellipsis, the fistula or the AVF is directly from the perforator into the radial artery. And therefore, theoretically, it should have a better flow straight into the superficial system. So just a recap of the wavelength system. I think I won't go into it. So peculiar to the wavelength, I think when we started off with the wavelength devices and then the ellipsis later on. So I had a lot of trouble with the deep venous anatomy. I think Robert shared earlier, usually the superficial ones, we have no problem. We're familiar with all the RC, AVF, BC, BBT, no problem. But when it comes to the deep veins, it's quite challenging, and also venous anatomy is more variable. And for retrograde venograms, because of the venous valves, a lot of time they appear incomplete. And then the valves also make wiring difficult, and they can get into spasm quite easily. And then when the vessel is small, you can perforate with your guide wire. I'll show you a specular rupture later on. Fortunately, most of these are quite benign. So the other problem peculiar with wavelength is firing blanks, meaning when you fire, but the AVF is not created. And that largely got to do with the alignment of the, the square magnet that I showed you earlier. And then, of course, the brachial artery puncture often has difficulty with hemostasis and can lead to hematoma or pseudoaneurysm. So I won't belabor the anatomy, just to show you some so-called classical anatomy. So the deep veins are called venae combinantes, right? Because they run parallel with the artery and in pairs. So over here you could see that there are also cross linkages between the two veins. Here it shows that they are of the same size, but oftentimes they are not of the same size. And the bridges sometimes can be also quite big, and there may be gaps in between. So this is where the perforator connects into the superficial system. Over here, it shows the perforator sitting on the ulnar vein, which over time we find that it may not be always true. It could be sitting on the radial vein and so on. So this was the case that I showed earlier. And when you first see this style anatomy, it might be challenging for you to so-called recognize the vein. Here, I have put in the label for you, but I have to assure you that it took a while for us to realize which is what, and now it's
a little bit better, we could identify it quite readily. So this was the case that I showed earlier. Oftentimes requiring a ulnar wire in the ulnar artery to help us navigate our way. So just skip through this case. Okay, venous spasm and perforation. So this is another patient. Again, you could see the anatomy is different from the other one. It's also coming retrograde. And you could see that we have perforated some veins. Same trick again, we put a wire in the ulnar artery. So manage to find our way. But unfortunately, it's so much spasm, we couldn't thread the wavelength catheter. So in the end, we had to use a balloon to gently angioplasty it. And with that, we are able to put in the venous side of the wavelength device. And then we got a spectacular rupture after creating the AVF. So this looks really scary, but fortunately, it's quite benign. So Milo has to press on it for a while. And then after that, the repeat angiogram shows a fairly decent venogram. And this is the classical appearing, the so-called bean-shaped endo-AVF. But you could still see that there's a lot of spasm around the vessel. So which is why we like to come distally. So distal venous puncture is, you can see the anatomy really easily. This is to compare with a retrograde puncture. So here the radial vein goes straight up the perforator into the superficial veins, and these are the brachial vein. So fairly straightforward to interpret. Okay, so oftentimes we do the venogram and the angiogram in the same, position. And here we would want to create the endo-AVF below the level of the perforator. So either here on the radial artery or on the ulnar side. Again, this is quite a typical appearance, a lot of spasm around after the endo-AVF creation. So usually when we inject through the artery and we see superficial veins, we are happy in the sense that we know that there is a communication already happening. So this is 1 week later, the brachial artery flow is above 500, which is good. And 1 month later, further increase in the brachial artery flow, and the cephalic vein flow is adequate for cannulation. So for the artery, we also like to puncture distally. Can we click on the video for this one? Yeah, so although it's a distal puncture, oftentimes it is enough to reflux and you could see the whole arterial anatomy. So there is no need to come from the top really. And the main advantage is we can then use a TR band for hemostasis. And the good thing about TR band is this thing called non-occlusive hemostasis. So basically, we apply the band is filled with air, and we inflate enough air so that there is flow across the artery, but no bleeding. And we know there's flow because when you put the pulse oximeter on, it shows there's a waveform. So this reduces the radial artery occlusion rate. Okay, so this we already mentioned earlier. So this was the case where the alignment wasn't very good. Sorry about the fluoro capture. We can't see. Essentially, for this case, can we click on this video, the last one? I think all of these are video. Maybe you click on them. Yeah. So we do the usual back and forth. The very first one as well. The very first one. Okay, so the usual back and forth. We thought we had it, but this one is during the firing. You could see that jump. But when we do the angiogram from the radial side, there's no superficial vein. So there is a problem with the fire. And then when we take out the venous catheter, we realize that actually it's faulty. There is mangled up. So we had to put in a new one. And this time around, it works. Can we click on this last video? So injection from the radial artery, now we see the superficial vein. Okay, So for the ellipsis device, I think Zutek already showed you a very nice case. I'll skip through this. So the main challenge with the ellipsis is because it's done under ultrasound guidance. So for most of us who are used to using fluoroscopic guidance, in your angioplasty procedure, this can be a huge hurdle to overcome, a huge learning curve. And the other thing is you need a fairly decent ultrasound. I mean, the machines we have today are all fantastic, but you may not have that quality of ultrasound. And once you do not have, not familiar with it, your puncture easily could cause a hematoma. And once a hematoma forms, everything becomes blur, and it's very difficult to see. Can we click on this video? In fact, both are videos. Can we click? So the first video showed the mapping ultrasound, very nice anatomy. The perforators are nice and big, but we had trouble in the final approach. Typically, we can walk down the perforator, but to enter the radial artery is in a different plane, and oftentimes, sometimes you get blood, but the guide wire doesn't go. So in this case, you could see the massive hematoma around the artery. When you have this, even if you could get into the artery, the distance between the perforator and the artery has become too big a gap for you to use the ellipsis. So essentially, this would be a failed procedure. Okay, so this is the last case. So this case actually, a good perforator size. We wanted to do the wavelength because the target sites for the radial is good size. The distal is also good size. But again, I had trouble puncturing. So although we have a fairly nice vein, we puncture, we could get blood, but the wire wouldn't go. And before you know it, everything is dog's breakfast. You can't see anything. So for this, because the perforator was quite good, we also tried the ellipsis approach. So walking down the perforator was okay, but again, the final approach led to a big hematoma. So after a while, you can't see anything at all. We even gone back and do a cut down on the radial vein to try to pass a wire through, but by that time, there's a lot of spasm. So for this case, unfortunately, it wasn't successful. In fact, in the same sitting, the surgeon created a radiocephalic fistula. So that worked for only 8 hours, and the fistula also thrombosed. So this is a very sad case, failure of both systems, purely due to puncture technique, so there is a learning curve for that. Yeah, so this is my final slide. So key factors for successful creation, I think very important to be familiar with the venous anatomy, especially the deep venous anatomy. Of course, you need to know the device, a good ultrasound machine. We prefer antegrade venous puncture and meticulous technique to prevent perforation and rupture. Thank you very much for your attention.
Hello, hi, good evening everyone. So I'll be just talking about 1 or 2 cases that we encountered during our practice here. So we have a good endo AVF team with Professor Jackie being in charge of it. So it's actually most of the interventions were done by her, and we kind of provided support wherever we could. Yeah. So let's move on. So I mean, in a sense, endo AVF does offer some theoretical advantages in terms of reduced wall shear stress and chances of juxtaanastomotic segment stenosis being low. But those kind of results have not yet been replicated in terms of actual practice. And in fact, the reintervention rates are close to almost 51%. And this one is paper by, I guess, Dr. Robert is he's sitting here. So he also, when he compared the patencies between the percutaneous endovascular AVF versus the surgical, it showed that the ellipsis device worked better in terms of primary patency, but the lower secondary patency was a bit lower on that side. And although they did some subgroup analysis, and it found that the surgically created fistula, which mimic the ellipsis fistula. There, the patency rates for ellipsis were better than the surgical one. So with this information, okay, let's move on to. So the usual post-maturation interventions are not different from what we do for our surgical AVFs, being balloon angioplasty being the most common one. Only difference is that the culprit inflow lesion is most of the times the perforator vein. And also most of the times we do some flow augmentation or diversion of flow from the basilic system into the cephalic or from the deep venous system to the cephalic system. And rarely we have to do thrombectomy, mechanical or pharmacomechanical. So first case is the usual 63-year-old guy with all the risk factors, plus gout, fatty liver, and he was not yet initiated on dialysis. His renal functions were fine. And an endo-AVF was created in May this year. During the procedure itself, we encountered some hematoma, which resolved with this gentle pressure and some gentle angioplasty of the spasmodic segment. So he did well, and but during this time his renal function deteriorated, and eventually he had to be started on dialysis. And during one of the admissions, before we could actually put the newly created AV access to dialysis, the ultrasound showed that there was some stenosis of the venous segment. Can we go back and play those videos? Sorry. Okay. Maybe the first one? Yeah, thank you. So it looks like there was some narrowing at the anastomosis and also in the middle part of the perforator vein. So this was a predominantly ultrasound guided intervention. We barely use any contrast. Cephalic vein access with 6 French, but as was alluded by the previous speaker, it was very difficult to enter the radial artery across the anastomosis through a venous access. Hence, we got a radial access at the wrist with a 4 French sheath. And then we managed to cross the AV anastomosis, and eventually we exteriorized the cephalic through the cephalic vein sheath, got a through and through X, and did most of the intervention from the venous side. During the same time, we thought of diverting more flow to the cephalic segment by putting coil into the cubital vein, which was connecting to the basilic vein. And then also one thing which we did differently was that we parked a balloon in the perforator vein so that we don't encounter inadvertent coil migration during all this deployment. There is history to it, which we'll come to it in the next few slides. So yeah, can we play the video? So yeah, we just, after that, we inflated a cutting balloon there. It was good. There were immediate good effects. The cephalic vein distended to roughly 5.5 centimeter. Volume flow was very good at 700 ml per minute. And that's how it looked on angiograms. Can we play the videos? So the top one is the pre-procedure. There is some narrowing at the anastomosis and the perforator, and the lower runs showed that it opened up quite nicely. So I guess that was not very challenging, very routine case. Now let's move on to the next case. So this is our very first case, endo-AVF, which was created using wavelength device. 79-year-old guy with end-stage renal failure secondary to proliferative glomerulonephritis. He was on hemodialysis for last 1 year using the tunnel dialysis catheter. A left mid-forearm AV anastomosis was created, but that did not last long. And so eventually he had vein mapping done. Decent size ulnar artery, 2.5. Lateral ulnar vein was about 2.3 millimeter. Perforator was good size, around 3 to 4 millimeter. So these are the ultrasound pictures of the same. So eventually we created a left ulnar artery to left ulnar vein wavelength fistula. this was really the first few, as I said, this was the first case we did at NUH. And retrograde access using the medial brachial vein. That's how the venous run looked like. That's how the arterial flow was. And then post-creation, there was good flow into the superficial venous system. And then we also ligated the medial brachial vein. And at the same time, I think Prof. Jackie likes to do this vein reduction by putting a small knot onto the basilic vein. So he was doing okay, 3 weeks post creation, everything looked good, veins have distended nicely. And almost 2 months after the creation, he was needled and was managed to undergo dialysis. The tunnel catheter was removed in February. After 3 more months, during his follow-up, we noted that there is thrombosis at the V site. The cannulation was shifted more towards the anastomosis to actually onto the cephalic vein. With that, it lasted for about a week. And again, on 17th of May, there was failed cannulation. And he was brought to ED to emergency OT to salvage it. That's how the run from the radial arterial access looks like. There is no flow in the cephalic vein now. In fact, you see that cephalic vein after a short segment just turns into these multiple hairy collaterals. It was crossed and then the routine balloon angioplasty was performed. At the same time, it was decided to divert more flow from the deep veins to the cephalic vein. And hence endovascularly, some more coils were put in. So that looks quite decent here. And in the same setting, there was some damage to the antebrachial vein because of the cannulation. So it was repaired surgically. But what happened after that was something quite unusual and scary also. In fact, all of the veins, coils that were used to divert the flow actually migrated back into the perforator vein. And then they had to be carefully fished out. Eventually managed to take them out and restore flow into the cephalic vein. Brachial artery flow was good, more than 1,000 ml per minute. So the story didn't end there. So fistula worked for 5 more days. And then there was again a lot of clots aspirated from it. Went to another round of angioplasty with a lot of recoil and residual thrombus. So this time the cephalic vein was stented using the Illuvia stent. And again, we thought of diverting more flow from the cephalic, from the deep venous system into the superficial system, especially this big collateral which just comes off after the anastomosis. Tried going into it endovascularly, but the angles and all were too acute, just very close to anastomosis. So we did a direct ultrasound guided puncture and put some coils there, which seemed to work reasonably well and managed to divert more flow to the cephalic segment. That's how the completion looked like, and the strong thrill was felt over the cephalic vein beyond the stented segment. Again, few more days, maybe in another 5 days, he came back with the same problem, difficulty cannulation. Now looks like the cephalic vein has thrombosed again. So this time around, he went and come back to me using the angiojet device. That's how the cephalic venous segment looked like, with recoil and residual thrombus. And at this time, more angioplasty, drug clotting balloon. And that's how the completion run looked like. Pretty decent. And brachial artery flow always was very good. So the month of mayhem was over, but and then he was closely followed in the dialysis unit. And then the story was not over yet. He presented in August. This time again the same thing, no thrill, failed cannulation. again brought through the hybrid OT. Can you help me play the first video? By now, I think we are quite familiar how his angiograms look like. The same story, contrast goes there. It ends in the cephalic vein, multiple small hairy channels. Again, back to where we started from, thrombectomy, angioplasty, long balloons. This time around, entire cephalic venous segment was covered with the Viabahn stent. And some more angioplasty. Every time when we did the outflow, we did the inflow as well. And this time around, we used a cutting balloon up to 6 millimeter. And that's how it looks like. Can you play the video? Yeah, so this is the completion end, but is it the end? I guess we know what is it. So there were a few learning points. I guess we have touched upon some of them during our previous conversations. Firstly, the suitability of the patient. We knew he was somebody who was prothrombotic because of his underlying gammopathy and all that. The cephalic vein did not have a usual straight course. And I think previous speakers have already touched upon that there are always these tiny multiple channels between the vena convavantes which keeps on diverting the flow. So there was never a good amount of blood returning into the cephalic vein. And I guess there are various other reasons we can find. So let's discuss that. Thank you.
If there is a better option, I would do the better option. But if I will not burn another bridge with a stent graft, if I still can use the basilic vein, but there is a completely stent grafted trash cephalic vein, why wouldn't try it? And yes, there have been reports of stent protrusion through the skin. Infection is less the problem rather than stent protrusion, but in limited cases, it's selective, you know, it's not a standard usual thing we would do. So I think we should, thank you. Proceed with the one before last talk, unless Jackie skips her talk, with pearls of case selection to maximize endo-AVF success. Good luck.
Thanks. Okay. I wish I met Robert earlier because we were actually struggling with this. So I'll just share with what we have derived over the past 2 years. So when we talk about endo-AVF, I think there are 4 big stages. Finding the right patient is key. Number 2, followed by creating the endo-AVF, which we have discussed a lot. And then using it when it's ready. And finally, the maintenance, which is something that is coming back to haunt us, as you can hear from the 2 cases earlier. And I think this is something that rings in my heart. You reap what you sow. So if you have a good patient selection, you generally get good outcome. And you have borderline selection, you're going to get borderline outcome. So you reap what you sow. So choose who you want to put in this pathway. Okay, finding the right patient. So generally, we look for patients that are not suitable candidate for radiocephalic AVF. And we look for the rule of 2 that we have heard of. Importantly, when we look at it, we need to make sure that the veins are at least less than 6 mm deep. Because you can have a successful AVF that's created, but the nurse can't cannulate it. So focusing on the not just the 2 mm, but also the depth is important in finding that right patient. And the diameter of the cephalic vein should preferentially be larger than the basilic vein because blood follows the rule of physics. And hemodynamics, you go to a path of least resistance. So if you have a very huge basilic vein, blood will tend to go to the basilic vein and not into the cephalic vein. So when we started this endo-AVF program, we were struggling. So I was taught in healthcare management, monopoly is never good. Then if you're not, monopoly is not good, not always good, then you have a duopoly. Then you have duopoly, then how do you decide who goes to where and make sure that both are sustainable? And then when we think through the whole process, we realize that the patient is not going to care whether their endo-AVF is created with Medtronic system or PD system. An endo-AVF to a patient is an endo-AVF, right? Then to the operator, the reality is that we need to pick cases that we can do in the quick time, right? We don't want to spend 3 hours creating an endo-AVF because the surgeon can create an AVF in under 20 minutes, right? So we want to have efficiency in creating that AVF. So we need to find that holy sweet spot in all this, and therefore we came up with this algorithm. So the first thing is look for presence of a perforator. If there's no perforator, there's no way you can do it. Goes for a surgical AVF. And if you do have a perforator that's 2 mm, we look for the distance between the perforator and the proximal radial artery. And if it's less than 1.5 mm, and that's good. If it's not, then if it's not less than 1.5 mm, and the target artery and vein is less than 2 mm, then there's no way endo AVF is going to happen. And this patient goes straight to a surgical AVF. Now, if the target artery and vein is more than 2 mm, and then there is a way to access to the target site, then we will do a wavelength system. Okay? If the distance between the perforator and the proximal radial artery is less than 1.5 mm and is favorable anatomy, meaning that you have a straight path to the proximal radial artery, then we will go for ellipsis system. If the anatomy is actually unfavorable, means a zigzag, and you do not want to be do a go cutting in a racetrack that makes them lots of hoops, then you go to a wavelength system. Okay, so this is our algorithm in our program. So the rationale is because for ellipsis, the vascular anatomy must fit the device. But on the other hand, wavelength is able to flex and change based on the anatomy that you have, right? And then the second reason is that the anastomosis is fixed in the ellipsis system. The proximal radial artery to the perforator anatomy is quite standard. So you just need to get there. But in the wavelength, it gives you flexibility whether you want to do a radial artery vein anastomosis or a ulnar artery vein anastomosis. And the time predictability for ellipsis is very predictable. You can go for your clinic after you do your ellipsis. But if you do a wavelength retrograde approach, it's large variability. You can spend 3 hours, so better close your clinic, do it on your non-clinic days. If not, you'll be late for clinic and the patient will scream at you. Okay, and the number of access site is 1 for ellipsis, 2 for wavelength. And additional step is that both actually need additional procedure during the creation. So in ellipsis, you need the angioplasty of the anastomosis, and in wavelength, you need coiling of the brachial vein. So that's why we actually find that because the main reason why we do this algorithm is because retrograde access can be very challenging, as you have alluded to by all the previous speakers, and we preferred an antegrade access. So that allow us to go in and get out fast. We don't have to spend 3 hours in the procedure. So this is a typical patient. Okay, we will scan. So the perforator is more than 2.5 mm. So definitely the patient go on to the next stage. But you can see that this patient is probably not suitable and we should not do it, because you can see that the cephalic vein is 1.6 mm, right? And then and the basilic vein is actually 1.3 mm. And the distance from the radial artery is 2.4 mm. So this patient can't do an ellipsis system. This patient should be eligible for a wavelength system. But do you really want to do a wavelength system? Because the outflow vein is good. But then even if you do create an anastomosis, the fistula is not going to mature. So in retrospect, shouldn't have done it, but we did it. I will show you the consequence of that. Now, on the other hand, this is a perfect patient, very nice, juicy cephalic vein that's about the same size as the basilic vein. And it's superficial enough, 2.8 mm, 3.7 mm at the lower and the middle part of the upper arm. And the distance from the radial artery is 1.4 mm. So technically, this guy is what Robert has said, will be eligible for both ellipsis and the wavelength system. But because he has very good access vein from the radial artery and radial vein, so we decide to do a wavelength for him. This is what I meant. So we actually map up and we decide which system the patient actually get put in based on their anatomy. Okay, and this is the result. You can see I have labeled it. You got the radial artery here, the jelly vein, you have the lateral radial vein. It leads all the way to the perforator, goes up. You can see none of the deep vein light up, and you have very good cephalic vein and basilic vein at the end of it. So good selection will give you good result. You reap what you sow. Okay. Why did I put this slide? Okay. So on the other hand, for ellipsis, for ellipsis system, now what about ellipsis system? Why is the anatomy important? Okay, so I think all jumbled up. So this is what we look for, a straight path to radial artery. Okay, so you can see that in this patient here, the perforator actually leads all the way down to the radial artery. So meaning that if you walk the needle down the perforator, you will hit the radial artery right on the spot without making any turns. Okay, and these are actually favorable anatomy. Essentially, what we are looking for is a straight path to the proximal radial artery. Oh, and this is one of the patients. You can see that the perforator comes all the way down. You can see shades of the proximal radial artery there. And then when you tilt your probe a little bit, you can actually see the radial artery. So these are all the ideal patients for ellipsis. Okay, so it's important for the posteriorist to perform the scan, visualize the course of the vein. Unblock may increase the size of the vessel, but don't expect miracle all the time. If it's 1 mm, it's not going to become 2 mm. Okay, so I will skip this. Okay, so this is some of the disasters. So this is the case that we show the borderline candidate that keep asking for it. So in retrospect, we didn't do it. And this is what happened. You get a jelly bean, nice jelly bean, but you have nothing for the nurses to cannulate. A successful AVF that's created, but cannot be used. And end up and this is a zoom in on the disaster. Now because in the pre-vein mapping, we already know that there was no way the blood is going to flow. And what you need to do is to bring back the patient. And then what I did was just plastic an entire new channel for the patient to be able to use the upper arm cephalic vein for cannulation. Okay, so this is another patient. You can see that the cephalic vein before we create was actually much smaller than the basilic. And blood follows the law of physics. It will go to the path of least resistance. And this is what you get at the end of it. You get all the blood that is going into the basilic system. And then you have that stump. Okay, 2 minutes more. I will show this. Okay, and then what you need to do, you got to come back in again, open up the channel, use a Mustang in this case. And then finally, you get a nice big cephalic vein for the nurses to actually cannulate. Also, again, these are cases, if you choose borderline cases, you must be prepared to come back in to salvage it. That's the conclusion at the end of the day. And that means additional procedure for the patient. And number 3, no variant, please. We want a normal anatomy. So this was a case that was put up. And then there was a loop in the radial artery. It looks good to do. And then what happened is it actually make a hairline turn. And lo and behold, we just couldn't get it in. There was a mistake. And then we were trying to hero. I called Liu from his clinic, Liu ellipsis. I said, hey, how come it take so long? I said, oh yeah, I think we didn't choose the right one. So we struggled and couldn't get that AVF created. So no variance, just go to the normal anatomy. Okay, valve will impede flow. And this is what happened when you have a valve there, you create a fistula. Now that label, that vein that goes into the upper arm is not the cephalic vein. Okay, don't be fooled. The cephalic vein is actually seen there with a venous stump. And what you need to do is actually to plastic it, and you can actually see that cephalic vein after after the endo AVF is created. Okay, and then this is what happened. Even after that, the valve still get retained inside and continue to impede flow. Okay, in conclusion, endo AVF can be very challenging. Avoid difficult, challenging cases when you first started off. Avoid small cephalic vein in relation to basilic. Avoid variants. Avoid valves in the perforator. Salvage angioplasty is feasible, but it's better not to choose the right. It's better to choose the right vessels at the beginning than to try to salvage it. Okay, with that, I end here. And I want to thank the teams for helping us study together. Thanks.